Testing audio, 1, 2, 3. Testing audio, 1, 2, 3.
Hi everyone, this is Donna Wilkinson, and I'll be presenting today's webinar. We're just going to give everyone a few minutes to join, so just hang tight. Hi everyone, this is Donna Wilkinson with Ameriflex. Thank you for joining our webinar today. We're just going to give about 2 more minutes for any stragglers, so just hang tight for about 2 more minutes. Okay, hi everyone. I think we're going to go ahead and get started. So welcome to our webinar. This is the Critical Healthcare Conversations of 2018. And just so you all know, the webinar is being recorded, so you all can go back later if you missed something. And it will also be on our website, which I'll share with you at the end of the presentation, but the slides will be emailed to you after the presentation as well, so just keep that in mind. A few other things. CE credit for this webinar is going to be awarded in 9 states. That's Arizona, Georgia, Illinois, Indiana, Kansas, Missouri, North Carolina, Pennsylvania, and Texas. So hang tight on that as well. We will have certificates coming your way so that you can make sure that you get credit. And other states are pending at this time for this course. So for those of you in other states, we'll have a list of your names and what state that you are in. So I'll certainly let you know and reach out if that list changes at any time. So while this course is listed as the Critical Conversations of Healthcare of 2018, these are actually conversations that while we're having them in 2018, these conversations are going to apply to 2019 and the future of your business. We just want to have these conversations now so that you're ready for what's coming. These are conversations and they're topics that you need to be up to date on now to prepare your business and your clients for future success so that you don't end up with stagnant growth and you don't end up behind the curve. You know, every day in healthcare, we're seeing continued uncertainty and risk and new regulations, new proposals, new trends that no one understands. Just lots of changes and uncertainty. So one thing that we know that's not going to change is that people need healthcare. But what has to change in order for you to be a successful broker, to retain these clients, to retain your clients and employers, and for them to retain their employees, what do you have to do to continue to grow? You've got to embrace that change. You need to answer that need and the cost of those needs. So with that, we have to decide how we're going to embrace those changes, what behaviors we're going to drive as professionals in this field to ensure that our clients are happy, they trust our advice, and that we're the experts, that they want to come to us time and time again because they know, that we're going to provide them with the right answers, both as the administrators and as the brokers. So this webinar is going to discuss some critical healthcare topics that will help you all decide how to embrace these changes and how to drive change in your client's behavior to set them up for success so that you are that trusted partner and they come back to you for advice year after year. So my name is Donna Wilkinson and I am Senior Counsel here at Ameriflex. A couple things about me. I am now a Texan, been here for about 6 years, but I am originally from Winston-Salem, North Carolina. I went to school in North Carolina both for undergrad and law school. I was at a law firm litigating for about 4 years right out of law school before I came in-house. And I am proud to say that as of this week, I now hold a 4.95 Uber passenger rating. I've been holding steady at the 4.91 for weeks, so I was very excited to put that bullet up there, and I want to make sure that I highlight that most importantly. I'm also proud to say that I am Senior Counsel here at Ameriflex and Aca. So a little bit about Ameriflex. Ameriflex is a third-party administrator with a commitment to putting our clients first. You know, we like to say in all of our meetings and all of our discussions that we make it easier. Benefits are extremely complex. They're constantly changing. They only become more complex. There's nuances, there's rules, there's laws, all these odd, strange plan designs, as you all know, that your clients want to create, small clients, big clients. But we work hard to keep up with those changes behind the scenes so that you all don't actually have to deal with all of those changes. We do that for you, and then we communicate it in a way that makes it easy for you and makes it easy for your clients. You know, dealing with the new regulations, the rising costs, we do all that without stirring it all up, making it more difficult, making it more complex. We figure out that hard stuff on our end so that we can and do make it easier for you guys and your clients. Now, Aca is a platform that's designed to help employers of all sizes implement and manage a direct primary care benefit, which we'll get into later for their employees. So employers can build and they can scale these multi-state networks of doctors, and they can design a plan that best meets the needs of their employees while giving employees choices, feasibility, and cost savings. Now, if you have any interest in DPC, even after this presentation, just want to know more about it, I definitely encourage you guys to reach out and just have a discussion with one of our associates. Again, even just to see what it is, talk about it. It's definitely picking up steam. It's definitely a way of the future. So it's quite remarkable and definitely a one-of-a-kind solution. So I encourage, if you have any interest in that at all, please reach out. So here are the topics that we're going to discuss today. Now, I know on their face, on this page, they look awfully boring. But once we get going, we're going to give you compliance tips, legislative updates, and some Washington whisperings that we've heard in the halls of the Capitol on our visits there. We do go frequently. New case law, and ideas for how you can design plans, some strategies you can come up with. Again, to be that trusted advisor to your client, helping them save money, navigate the murky waters, and again, making you the trusted advisor so that your businesses continue to grow, so that you continue to grow in this changing market. So first up is prescription medication, prescription drugs. This is the first big topic that it just continues to be an item of discussion. Prescription medication, the costs, price transparency, who covers what, different tiers, big pharma, mergers on the horizon. You know, this year we saw a particular drug, a potentially life-saving drug, increase by 5,000%, Daraprim actually, and that was done by everyone's favorite big pharma bro, Martin Shkreli, who is now serving a lovely 7-year sentence in prison for fraud. So again, while he's in prison for fraud, he actually didn't go to prison for raising the prescription cost by 5,000%. What he did was actually perfectly legal at this point. Now, again, that was back in March. So since then, the media climate around prescription drugs and around price transparency, it has not gone away. I want to hit some of the highlights of the last 6 months of where the interested parties are on this issue. It's important to this administration, and I think that what we're going to see are some measures put into place that bring more transparency. As this quote shows, our U.S. HHS secretary, he's just come right out and said that basically every single meeting he has with the president, they never once leave without talking about drug pricing. It is on the forefront of their minds constantly because they see what's going on. Prices are rising, rising, and rising. So we'll start with the administration. The Trump administration did submit a formal notice titled HHS Strategy to Lower Drug Prices and Reduce Out-of-Pocket Costs. He submitted that formal notice to the HHS, and he basically just said, here's my formal notice. I don't know how to do it, but y'all go figure it out. So no specific details on what that plan actually, that blueprint entailed, but we do know that Trump and the HHS Secretary, Alex Azar, they've been working extremely closely on proposals centered around decreasing drug prices and ensuring that the discounts that the manufacturers, the PBM middlemen, ensuring that those discounts are passed on to consumers. So both Azar and Trump, they are fans of putting a cap on out-of-pocket drug costs for Medicare enrollees, which is great. They're also big proponents of allowing the states to negotiate the drug prices under Medicaid. And part of that is because a population in one state is completely different from a population in another. So having one overarching price may not make sense for Medicare. With that, another idea is to limit the growth rate of certain Medicare drug payments to only inflation. This would require insurance to pass drug discounts to consumers. This would ensure, pharma bros, like we mentioned, our friend Martin in prison now, that he can't jack up a price for no reason by 5,000%, that he may only be able to increase drug prices by the rate of inflation. So that would be a good measure there. It's important to this administration, and I think that we're going to see some measures put into place that bring more transparency. Just as that quote showed, the administration's blueprint for this formal notice, it identified 4 key strategies. They want to see improved competition, which I'll talk about here in a minute. better negotiation between all the parties because there's so many involved, so many that are getting kickbacks and different rebates. They want to see incentives for companies who lower their list prices and lower out-of-pocket costs. They want to give incentives to those companies. So the administration is pushing for this hard. And the FDA, they have actually answered this blueprint. When the administration said, we want improved competition, the FDA came back and said, excellent, we have a proposal that would speed up the FDA approval for generics and over-the-counter medications. Now, approval of these products, it could favorably impact some of the drug classes. So if this proposal goes into effect, which I believe that it will before this administration is out, you're going to want to start reviewing closely the pharmacy plan designs, how different tiers are set up. If there are more approvals for generics and over-the-counter medications, we're going to want to make sure that the pharmacy plan designs are positioned where you and your clients can reap the benefits from this increased competition. They're also requiring manufacturers, or they plan to require manufacturers to include a drug's list price in direct-to-consumer advertising. You know, we see these advertisements everywhere for new drugs and old drugs. Well, there's not much visibility, and by requiring manufacturers to put a list price in that consumer advertisement, that's going to provide an incentive to these drug makers to change their pricing behavior. It certainly will. So that measure going through, we're pretty positive is going to happen. Not this legislative calendar, but definitely before this administration is out. That's something I have a feeling we're going to see. That's something that is has bipartisan support. So moving on to a few legislative and judicial actions that we've seen. The first is a Massachusetts law firm. They filed suit against some big pharma firms, and they filed it on behalf of patients, which was interesting. They filed it on behalf of patients, claiming that these patients' insulin prices of hundreds per month, which they rely on day to day to live, again, these insulin prices were increased for no reason, and this forced diabetics to starve themselves to minimize their blood sugar while skipping on doses. So Massachusetts files this lawsuit, and some other states got their binoculars out and said, oh, really? Now 5 other states are investigating as well. So we can go ahead and see this is probably, again, going to settle out of court because it's going to be hard for some of these companies to justify why the price increased suddenly for no reason at all. Now, when this lawsuit happened, Novo actually was like, oh, crap, this is not good. So what they did was they took a bunch of money and they poured it into D.C. They poured it into a PAC and poured it into federal campaign donations so they could have a louder say in how and when pharma can increase prices. So it's notable that in 2017, Novo actually spent about $3.2 million in lobbying in 2017. So they really focused on this, which tells me they're a little scared because in comparison, Eli Lilly, while they're also named in the lawsuit, Eli Lilly only had $535,000 in political spend that year. Now, okay, Eli Lilly had less to spend. They might be taking some culpability here, but Eli Lilly is not a saint in all this. So the next lawsuit they're listed, California recently put forth a new law. It's into effect now that requires advance notice of planned price increases for prescription drugs. And Eli Lilly, they've basically informed consumers. They've informed the state of California. That's a really cute law. But guess what? We're not going to follow it. And we're not going to follow it because there's currently an industry lawsuit that's challenging that law's constitutionality. And until that's resolved in court, we don't feel that we need to follow that law. So that lawsuit, it's a lobbying group known as PhRMA. They filed this lawsuit against the state of California. And basically the argument is California, you can't make a law that says drug manufacturers can't raise prices without notice, because that's affecting interstate commerce. You're affecting manufacturers all over the country. You don't have that right. So that lawsuit is pending, and quite honestly, I do not know where that is going to end up. So we're keeping a close eye on that. If other states start to join, if it heads off to maybe a federal court, we'll keep an eye on that and keep you guys abreast on what's going on there. So moving on to the legislature, we are, which is terrifying, less than 50 legislative days away from the November midterm elections, which everyone is just nail biting. Who's going to take over the majority? So in our recent visits to DC, we go up there quite frequently. When we were up there and we met with lawmakers, you know, we're not confident that these next two bills I mentioned are actually going to get passed this legislative season. While both have bipartisan support, there just isn't enough time this year. But we are confident that next year we're definitely going to see some movement. So we're kind of in a wait and see pattern. But again, we're confident in the movement of more individuals, more companies, and now lawmakers on both sides seeing the value in health savings, flexible savings, both types of accounts. So for House Bill 6199, basically, HSA funds will now be able to be used to purchase over-the-counter medications. So this would allow individuals to have an to have an HSA and be able to not just use it on prescription medication, but anything over-the-counter without a prescription, which would be fantastic. That way they can save more money, save it tax-free, and use it how they wish. They can make a consumer-directed decision. Also in that bill, it's going to allow individuals to have an HSA even if their spouse has an FSA or vice versa. Because as it is right now, if you're a married couple, one of you cannot have an HSA and one of you cannot have just your typical FSA. That is against the tax law. But this law would actually change that so that there'd be even more tax savings. And again, there is support on both sides. I just don't think we're going to see movement on it, however, until next year. Now, House Bill 6311, that actually increases the HSA contribution limits, and it allows individuals over the age of 65 who are in Medicare Part 1 to continue to contribute to their HSA if they're in a high deductible plan, which is fantastic. What a great way to continue saving while in retirement, while on Medicare, keep stashing away that tax-free money. That would be great. And again, that does have bipartisan support. So both options expand the use of HSAs, which is only going to help individuals in the long term. But even those who need prescription medications on a daily basis, these bills do help those individuals save even more on out-of-pocket expenses because of the tax savings. And actually, there was a review of about 13 different scientific studies that found that chronically ill employees who they take their medications as prescribed, they have significantly fewer sick days and short-term disability absences. Now, this review, it was conducted by a nonprofit, the Integrated Benefits Institute. So what this study suggests is that substantial savings could be realized by your clients, the employers, by increasing rates of adherence among employees with certain chronic conditions. If you all can help a client, you can help your client as a broker reduce lost productivity, couple that with employer tax savings, and the employee now has a tax-free savings account, your client is going to be doing better than the majority of employers in America, and will see that these accounts actually work. And really, the employers, once they set up an account like this, they can be pretty hands-off. Once it's set up, it is pretty hands-off as far as the HSA is concerned. So even more, that same study showed that when copays for generics are eliminated completely, that if employees have a tax-free account, whether or not the employer puts money into that tax-free account that they can actually pay from, adherence increases among those employees. And that's for both high-paid and low-paid earners, so it did not matter. Another study from July 2018 by the Employee Benefit Research Institute, it showed that the relationship between the plan type and the type of specialty medications for those most common conditions that require a specialty medication, the plan type that they had, whether it was a HMO, PPO, HRA, or HSA, that actually had no impact whatsoever on whether those medications were filled. So why not give them an option that gives both parties, the employer and an employee, tax savings, because they're still going to fill those specialty medications. It just further incentivizes them to fill it. So keep that in mind when you're talking to your clients, talking up these accounts. When everyone's looking to save money, this is really where it could be. As it also relates to medication, a few other things that we're keeping an eye on is this Cvs Aetna Merger. $69 billion, that's a lot of dough, people. So some people are nervous about it. They're nervous that Aetna might actually limit the choice that patients have, that they might limit patients to say, oh, you're sick? Well, first you got to go to a CVS Minute Clinic before you can go see your doctor. They're also a little nervous that maybe Aetna patients will only be able to fill prescriptions at CVS pharmacies. So that would only cause more transparency issues, so I'm not quite sure how all that will play out, but we will see. Another thing that we're keeping an eye on that we heard about when we were last in D.C., and again, there's not a whole lot out there about it, it was just some whisperings that we heard, is how they want to now structure rebates. We all know how rebates work around prescription drugs, but Trump, the administration as a whole, they basically want to revisit how rebates are handled with the intent to lower cost. But how I actually think this is going to work is we're going to get rid of rebates altogether. They just won't exist. However, I don't believe it's going to have the same impact that we all think it will. So basically, the intent is to lower the cost. So if we get rid of the rebates altogether and we just ask Big Pharma, PBMs, we ask all them just to use their market power to get the discounts on the front end rather than on the back end through rebates, I mean, really, we're all ending up at the same price. So I don't actually know if the prices will be lower. The structure is just going to change. So lastly, the administration is asking whether the PBMs, these middlemen, whether they should be considered fiduciaries, whether they should be obligated to act only and solely in the interest of those from whom they manage drug benefits. So that would mean they are going to be held accountable for negotiating in the best interest of the plan instead of themselves. That would preclude them from accepting payments from manufacturers. So kind of last point here, the cost of prescription drugs specifically, it's expected to be a major campaign issue. It is a major campaign issue. It's an issue we are all dealing with. So ahead of these November elections, you're going to see more about what people plan and what they want to do. Keep an eye out for all that, but there are a couple things we do think will happen, specifically these two House bills I've mentioned. Expect to see more. Expect for it to change really quickly because my very last point is last week, HHS, he came out, Alex Azar, and he said, guess what, guys? Actually, I have the authority to do whatever I want. And if I want to make a change without Congress, I'm going to. And so it really could end up that Trump and Azar, they sit down, just those two, they come up with a plan and they sign it into law. And until someone attempts to file a lawsuit against that, that could be what we get. So we'll see how that plays out. Okay, next topic, ACA updates. For those of you who live under a rock, that would be Obamacare, the Affordable Care Act. So this quote, ACA repeal is like Fight Club. The first rule is, let's just say, not to talk about Fight Club. That's from one GOP operative who's going to remain nameless. So here's where we're at. Republicans are not going to be in a position to try again to repeal ACA, in part because their last effort was so unsuccessful. It was so unpopular. Healthcare is front and center right now in the Democrats' bid for the House majority, and the polls are showing that it is working. Many Republicans, unlike last election, they are not campaigning on ACA appeal like they have done in the past. So we can get all to what we heard in Washington later, but let's first discuss just a couple of updates and measures that were successful. So first, I think that we all know the individual mandate, it was reduced to 0. So when people say that the mandate was eliminated, that's actually incorrect. The mandate is still in the law in black and white. You can read it, but it was just reduced, amended down to 0. So in theory, what everyone thought was, oh my gosh, we are going to remove this individual mandate penalty. It's going to result in lower enrollment levels in the individual market due to reduced incentives for individuals to purchase health insurance. And as enrollment in the individual market declines, the morbidity of the individual market risk pools is only going to increase because those healthy people are less likely to stay in the insurance market than their less healthy counterparts. Here's the thing, I'm not quite buying it, not wholeheartedly anyway, because the individual market in the last few years, they have already experienced high rate increases. Every year, it's increased pretty substantially. And we've already seen issuers exit the market. So this has already caused individuals who are healthy to leave the market. They've already left. They've foregone coverage. So the impact of eliminating the mandate is not what will cause a market shift, but instead what could cause a market shift is the subsidies that are provided. So unsubsidized members, those who don't receive any help in paying for their premium, they are going to be more likely to exit the market. Now that there isn't an incentive to stay, what's the point? Therefore, I believe that every state is going to see a unique outcome from this. Every state's going to be unique. And the changes to the risk pool brought by this $0 mandate, it's going to vary state by state. It is worth mentioning that some states are contemplating a state-based mandate that they will make those residents in their state have health insurance or face a penalty. But I still have a feeling it won't have the same effect that we all think that it will, with those mandates I just discussed. So, and to be clear, this mandate that was reduced to 0, that is only for the employees. The employer mandate is still in effect, so that is still attached. Cadillac Tax, I know a lot of you probably know this as well. Once again, Cadillac Tax, not just a tax on your hybrid Escalade. That Cadillac Tax, as it's called, it's now been delayed to 2022. We've kicked the can down the road once again. So this is that tax that is on high-cost employer-sponsored health coverage, and the tax is 40% of the cost of health coverage that exceeds some predetermined threshold amount. And I don't have those in front of me, but they're out there. So the tax is basically based on the total cost of each employee's coverage that's above that threshold amount. Now, we here at Ameriflex Senior, we're working with many industry groups and PACs to have this tax removed completely. But for now, we keep kicking it down the line. So for right now, we're happy with that, and we're doing our best. So just know that. What's interesting, though, is that the Republicans nor the Democrats are actually a fan of this tax. Republicans don't like the tax because it's not up to the states. And it's a tax on employer-provided health insurance, which to them makes no sense. And the Democrats don't like it because it is extremely highly unpopular among organized labor. So here's the issue. Neither party likes it. Both parties want to get rid of it. However, they don't want to get rid of it ahead of the November election because neither party wants to let the other party go in and vote on it and look like the big bad, hey consumers, hey constituents, look what I did for you. I got rid of this tax. Am I not the greatest? Because we all know we might have time to pass it through the House this year, but we won't have time to pass it through the Senate. Therefore, it's only going to make a counterpart look more popular ahead of a vulnerable November election without the measure actually becoming law. So I don't think that we're actually going to see any more on the Cadillac tax this year, but I do think that we are going to see it next year for sure. Back to our Fight Club quote, the ACA repeal. Now, if someone gets really brave, and there's a couple of them out there, and they want to throw up a bill to repeal ACA again, what will Mitch McConnell do? WWMD is what I ask myself every day before I go to bed, because he could throw it up for a vote. He could say, why not? Let's see what happens. But I think that's unlikely, again, because we just don't have enough legislative days left. What we're hearing out of D.C., and this is interesting, is that the Democrats are actually loving that the Republicans tried to repeal ACA. The Democrats are like, wow, guys, great job. You campaigned last year on this, and you did very poorly on it. So Democrats are taking that terrible vote, that terrible repeal, and they are just hanging it around the necks of the Republicans, and they're saying, wear this proudly, my friends. And that's as a way to get more and more votes. They're just selling it as the Republicans tried to take away your health care. They tried to take away your pre-existing conditions, and it didn't work. We shut them down. We're the heroes. Vote for me. I'm a Democrat. Republicans at this point, they're trying to remain cool, calm, collected, and they're discussing other measures besides repeal at this point because they know it did go so poorly. And that's kind of part of our issue with where we are. We're now, instead of repealing this whole thing and starting over, we've got a hodgepodge approach from both parties on how to tackle health care, between the HSA bills that are coming through, association health plans, short-term duration coverage, suspending the risk adjustment program, medical device taxes. We're putting together this piecemeal hodgepodge of quote-unquote solutions. So I have a feeling that's what's going to continue for a while because everyone's a little scared to throw it back up and have it blow up in their face. So without whole-scale reform, honestly, both sides are going to continue to contemplate this piecemeal approach to fix aspects of the system. So I think repeal is a far, far away for now, and we're just going to have to take the approaches that they're giving us as of today. A few notes I do want to remind you all of as it relates to your clients and your business. We are starting to see that the IRS is actually serious for once about assessing employer penalties. They are sending out some pretty serious 226J letters. Those are the letters they send out that say, employer, you did not offer qualifying health coverage and you now owe me $2 million or whatever it is. That's a little extreme, but the fines are very large and it's very, very scary, especially if it's true. So the IRS is assessing these employer shared responsibility payments or the tax penalties against large employers who did not offer that qualifying health coverage to at least 95% of their full-time employees. So again, the ACA reporting requirements, y'all, they still apply. Large employers, they still need to file that 1095-C with the IRS. They still need to send them to their full-time employees each year to document their compliance with the ACA. Now, if you all have any clients that get these letters, you've got any questions, you need support on the ACA employer compliance pieces, we do offer compliance products for that. Happy to help answer questions, read over a letter, kind of figure out what to do because we are able to get some of these reduced. So definitely reach out to me and let me know if there's something going on. I'm happy to look it over and help because this is a brave new world with these letters. And in talking about the ACA, you know, one area where when employers are looking to save money, one option is direct primary care, as it fits under the ACA as insurance. So DPC, direct primary care, it is insurance in the federal government's eyes. The IRS interprets DPC arrangements as health plans under Section 223C. So it could be a viable option for some of your clients if you're looking for a lower cost option with just about the same amount of coverage. So we're going to talk about DPC later. That's another topic in this webinar, but do keep that in mind for ACA purposes if you've got an employer who really needs to cut back costs but still needs to offer their employees great service. So the last point as it relates to ACA, the lawsuit, the pending lawsuit. Not to be outdone, a lawsuit was filed by Texas, yeehaw. They filed a lawsuit against the federal government to enjoin Obamacare. due to the zeroing out of that mandate penalty for individuals. So these 20 states got together, again, led by Texas, and they're arguing that by Congress reducing that mandate down to zero, that's fatal to the entire law, that the mandate, this entire law, should now be unconstitutional. They're asking the court, and they have filed here in a federal court in Northern District of Texas, they're asking the court to prevent the federal government from enforcing the entire thing of the ACA Obamacare, or at least at a minimum to strike down the laws surrounding guaranteed issue and community rating provisions alongside that mandate. Well, again, not to be outdone, 16 Democratic states came in, led by California, and they said, whoa, we got to intervene in this case. Because here we have a lawsuit, Texas versus United States. Who represents the United States? President Trump. Do you think President Trump's going to try real hard, tell his people to try real hard to defend this lawsuit? He's not. He's not a fan of Obamacare, so he's not going to tell them to try real hard. So these 16 Democratic states came in and said, listen, the stakes are high. They are extremely high in this case, and we have got to represent our states and our constituents' interests, and we believe our interests are separate from the federal government, so we need to intervene. So the intervener states argue, and they're raising concerns about the federal government's position, and the government has previously stated that the ACA's position on guaranteed issue and community rating provisions, that they should fail if the mandate fails. So the government has already said, yeah, the mandate's not there, the rest of the law shouldn't be there. So that's why these states were like, we got to step in. So in May, the judge, who by the way, the judge it's in front of, he has already ruled in a previous case against the ACA, so we already know this judge is not a fan of Obamacare. He did allow the 16 states to come in. I honestly, I don't believe that this case is going to overturn or repeal ACA, and I'll tell you why. Cases like this typically turn on an issue what's called severability. So if you have a law made up of 17 pieces and someone strikes down 2 of those pieces, the argument always is, can the other 15 pieces still stand without the other 2? And typically it turns and it hinges on, well, what was Congress's intent? When Congress took away that individual mandate, they had every right, ability, and quite frankly, they could have struck the entire thing. The entire ACA they could have struck, but they didn't. They only struck the individual mandate and a couple other pieces. So I think that it's pretty clear in the intent in the tax bill that it was to keep the ACA insurance reform, but they thought that it was okay to take the mandate out and leave the rest alone. So it should also be noted that a couple of pretty high up career attorneys for the Trump administration, they've actually withdrawn from the case, which it only suggests to me that they're uncomfortable with the legal argument and they know that that's where the case will hinge on, and they just don't feel comfortable arguing about it. So oral arguments are set for September 10th. DOJ, they've said they're not going to defend the law in court, so this is up to those 16 states led by California. Yes, so we will see. And several federal government entities have come forward, organizations have come forward and said, even if this case is successful, we do not plan to follow this case law. So Centers for Medicare and Medicaid Services Administrator Seema Verma, she came out and said, even if this case wins, I don't plan to follow it. So we've already got people who were like, sure, do whatever you want in court, but until Congress or someone else tells me I have to, I'm not going to be doing it. Okay, moving on, Hipaa. Oh boy, Hipaa. So Hipaa is just a favorite topic of mine as an attorney and as our Hipaa privacy officer, but it is one that I know you all are rolling your eyes at, and I'm going to watch our attendee number probably decline at this point. That's fine. But because most people think, yeah, I know what Hipaa is. You don't share information. Don't share confidential information. I sign a notice each year at my doctor's office. Boring. Move on. I know what to do, what not to do. I'm careful. I'm good. Or, besides, they only go after big companies, they only go after health systems, they go after those with deep pockets. They're not going to come after me with what I do day to day, the stuff I do day to day. I'm here to tell you, times they are a-changin'. So I am always thinking about Hipaa, and I really wish the rest of the world would think about it with me because, partly then I'd be more interesting at dinner parties, but anytime something comes in the door for me, an issue, a question, new contracts presented, the first question I ask that you need to ask, are there any Hipaa considerations here? It keeps me up at night. And in a minute, you're going to see why, because the repercussions are just business altering. Here's a good quote. So basically, OCR, they will shut down your business. They will shut down your client's business. You could be personally in a heap of trouble, personally. So when I think about these types of things, it makes me what I call a hypochondriac. Problem with the webinar is I can't hear if you guys are laughing or not. So I'm assuming that you guys are laughing hysterically, that I'm a hypochondriac. But moving on. I am one because I think about it all the time, and I bring it up every chance I get, because not only is the federal government, the OCR, serious about upholding Hipaa, but states have now raised their hand. They've now pulled a WWE move, and they've said to the federal government, tag me in. So here's a quote from the OCR director as it related to a recent settlement. And now the states have the ability to come after entities too, big and small, because we all know states are needing dollar bills. They are coming after the small guys, and you can guarantee that they will continue to do so. So, with that being said, they will, in New York, the Attorney General issued a $1.15 million settlement with Aetna for a mailing that went out detailing HIV medicine that certain members were currently on. That could be seen through the visible window. In New Jersey, they issued another fine. It was actually a third party who caused the breach, but it was actually a third party who caused the breach, but they held the group accountable. So that's just something to keep in mind. Another big one we saw was MD Anderson. They had a $4.3 million fine for one stolen laptop and 2 thumb drives, which were missing. 3 devices were missing, and it caused a $4.3 million settlement. That's insane. Last week, a judge approved a $1.5 million settlement against Anthem, and that's just because hackers targeted them, and they got in, and they got a bunch of stuff, and it was scary. So takeaways for you brokers: encrypt, encrypt, encrypt. Don't stop encrypting. As technology advances, you can expect that the OCR is going to continue to crack down. You got to start thinking about these things now, and you really got to understand the privacy and security rules. If you don't understand the rules, if you don't have a trusted partner who does and can help you and your clients become HIPAA compliant, especially as it relates to these new technologies, you've got a problem. It's important to align yourself with vendors and partners that take it seriously. If it doesn't keep them up at night thinking about new risks and controls, they may not have a full grasp on what's going on. So please keep that in mind, because there's some serious ramifications. All right, next topic, opioid epidemic. So this is not the most fun topic, but this has become any and all lawmakers can talk about. So basically this quote here from Mr. Azar just speaks to the FDA's issuance of guidance that encourages development of more drugs on this issue. And there's a lack of access to those medications. So first, I want to talk about what's coming out of D.C., what we've seen. I've never seen so many bills packaged together like this and pushed through so quickly without a full budget review, but basically 56 bills were pushed through in just 1 week. It is on everyone's radar. They don't care how much it costs. They know it's an epidemic and it's a problem. So one bill, and everyone's for it, Democrats, Republicans, everybody's for it, but one bill intended to address the growing epidemic that was passed in June by the House is now being kind of pushed against, because there's a group who's saying, well, you need money to do all this, but by by finding the money to do all this, you're taking away from another condition, specifically kidney disease. They took money away from that. So again, everyone wants to help, but we don't know where the money is going to come from. We saw last week that the DOJ moved to block 2 Ohio doctors from prescribing opioids. Jeff Sessions literally just came out and said, hey, I have the authority to do this. You 2 doctors, you're not allowed to do what you do anymore. So they're going to start calling out doctors individually, and that's dramatic. It's the equivalent of Sessions walking into your business office and saying, I don't like how you're doing things, so you're ordered to stop doing it as of today. End of story. And also last Thursday, Trump did tell Sessions that he believes that those who are convicted of illegally dealing some of these opioids, they should get the death penalty. Let that sink in how serious that is, how serious they're taking this. A drug dealer of an opioid could get the death penalty one time being prosecuted and found guilty. And what's interesting is they could be have an execution using the exact drug that they illegally sold. That's crazy. States are now filing lawsuits as well, specifically against Purdue Pharma. Purdue Pharma does manufacture the OxyContin drug, and what they're saying is that they deceptively minimize the risks of the drug's use in order to boost sales. So Purdue Pharma, they're not going to get out of this scot-free. It's going to settle out of court. They've got some culpability, and there really is no denying that their drug did kill thousands, and it still continues to kill thousands. So with all that said, how you need to start doing some plan design around this is that we know there's going to be a big push towards medication-assisted treatment. I want it to be known that substance abuse treatment, it is eligible for reimbursement under FSAs, HSAs, or HRAs. That's important because I think if you put that forward in meetings with your clients, you're going to see that it's going to set you apart to bring up the hard-hitting issues, to develop the best plan. Ask them. It's a chance to educate on what these accounts actually cover, because this is a much bigger deal than what any of us think, and it exists in every community. I think that what you have to think of as brokers is just when helping your employers come up with a plan is, does your plan network include different treatment options? Do they live in rural areas, small towns? I'm getting these questions more and more, at least 2 or 3 a week, on what does our plan cover, what does my HSA cover. DPC can also offer options for employees who are reluctant to walk into a counselor's office. Many employee plans who include this option, the DPC option, that are going to allow doctors to provide services over the phone, over the internet, chat, all that kind of stuff. That's going to help build relationships with those patients and drive them to get treatment. And last point, because I know it's not the most fun and enjoyable topic, but I do believe we're going to actually see DPC help on the front end and get ahead and prevent the opioid addiction. With DPC, if an individual has a doctor that they're building a relationship with, not just your once or twice a year visit for 7 minutes, but a doctor that you can email, text, chat, go see whenever you want. You have a doctor and their staff who, for whatever purpose, if they have prescribed an opioid, they can be monitoring you to make sure it's not being abused. They can make sure that there is not a failure with the adherence. That's where we failed these folks, is that we've put something in their hands and doctors said, see you in a year, and have no other relationship with them, and that's where DPC can come in. So speaking of DPC telemedicine, that is our issue number 5. And, I hear some of you saying, Donna, isn't direct primary care just some unicorn? It's too good to be true and must have hidden costs for the patients, and the doctors won't actually be available. No, direct primary care is not just a beautiful unicorn that exists only in our imaginations. Direct primary care is an innovative alternative payment model that improves access to high-functioning healthcare, and it has a flat, affordable membership fee. So no fee-for-service payments, no third billing, and the best part, you're building a trusting relationship with your primary care physician. So with that being said, interest in this model is definitely growing. Primary Care Enhancement Act, I kind of mentioned this bill before, Bill 6199. This bill is going to allow millions of Americans with HSAs to have access to the affordable primary care from a DPC doctor of their choice. This would allow an individual to have an HSA, and that they could use those HSA funds tax-free, to pay for their DPC monthly fee. So this is a unicorn, actually. Can you imagine having that much access to a doctor that you trust by text, email, phone, video, in-office visits for only $150 a month, and you could pay for it with an HSA? That is a unicorn. So again, that bill passed the House, and while we think it will pass the Senate next year, we don't think it will pass the Senate this year, we are very excited and anticipate movement next year. So that's very, very exciting. Some state laws are adopting DPC-related laws, but for the most part, they're just trying to remove DPC from the law of state insurance regulation. That way it's just not complicated, and they don't have to be subject to a bunch of those messy, gross, annoying insurance laws. So again, here are just a couple of the defining elements of the Dpc model. You've got that choice piece, you've got the elimination of fee for service, and these doctors, because you're building a trusting relationship, the DPC providers are committed to being advocates for their patients. They have more time to make informed referrals, they support their patients when they're outside that traditional system, and the ultimate goal isn't just to simply treat a disease, it's health and well-being. So we can talk a little bit about how this can be structured. For telemedicine, one thing I just wanted to say was that telemedicine you can now pay for with Medicare. That was a law that was passed recently. It was part of a bill in January and then also part of the federal tax bill in February. So I did want to mention that so that you all know that that's now covered under Medicare, which is great. The fact that doctors can now bill the government for telemedicine monitoring, it's groundbreaking. It's going to result in better care for those on Medicare. For DPC, it can be structured under the employer's health plan. And by doing that, it triggers ERISA, it triggers COBRA. But here's why the employer wants to offer it under their plan. It's convenience. It's hard for employees to take time out of their workday to take themselves or a child to work. And in areas where doctors' offices are limited, this is a great, great option. So it keeps the employees at work. It reduces cost. And if it's communicated appropriately to those frequent flyers, it's a much less expensive alternative for alternative care. It helps manage those chronic illnesses that employees or relatives with chronic conditions are finding this model. They're finding it easier because they're monitored virtually instead of having to go into expensive doctor's visits. So, I want to say at this time that DPC can be paid for using HRA and FSA dollars. And then once this House bill is passed, you can use your HSA dollars as well. So it'll be such an easy resource for your clients to use. Structuring DPC with an FSA or HRA, it just makes sense. It just makes sense money and sense wise. Saves the employer money, time, resources, productivity. Employee engagement will go up, and it saves the employee time, headaches, money, and most importantly, it saves their health because they now have a trusted advisor on their side. Virtual encounters are only going to become more commonplace. So keep that in mind there. Next issue, millennials. Woo. So just like the baby boomer generation, this cohort of young people, we carry influence. And I say we because that's right, folks, you've been listening to a millennial. This morning, I took a selfie. I had a $5 latte out of a biodegradable cup, and I ate a slice of avocado toast, and I drove here to put this webinar on for you. You are welcome. While some millennials fit different stereotypes, in the healthcare space, what they're doing is they're prompting and demanding a much different structure and model than ever before. They've got a greater emphasis on technology, faster delivery of care, and they want virtual options. The only way to step into that new growth, to see more dollar bills in your pocket as a broker, is recognizing that your customer, your client base, is changing. Here's an example. Since 2011, Johnson & Johnson has seen a 20% decline in its sales for baby care, and they used to be number one. Do you know why that's declining? Well, that's because right now, the people who are having babies, they're millennials. And do you know what Johnson & Johnson doesn't get? Millennials. They don't get millennial moms. They don't get millennial parents. The executive vice president even admitted it. They said, we became complacent. We didn't want to mess with our success over the last 20 years. We assumed we were a trusted brand. We kept going, and we failed to see the evolving needs from millennials, and now it's too late. We're going to try to change the brand, but we don't know. We just don't know. And here's a great quote from a book about millennial myths if you guys want to read. If you're understanding where this industry is headed, then who your customers are now and really the next 5 years, you're setting your business up to be in the best position possible. Trends, nothing shocking. They love social media, love apps, love wearables, flexible payments. They want care fast. You know, they turn to the internet for everything. We've been called the drive-through generation because we want things quickly and efficiently. So they prefer those retail clinics. They prefer acute clinics, very similar to that Dpc model where they can text or online chat through an app. They don't want to schedule an appointment over the phone and wait 20 minutes in a waiting room and wait in the back for 20 minutes and only see them for 7. They want upfront estimates. In fact, millennials are more likely, 41% of them say they request pricing up front, as opposed to only 21% of baby boomers. So that's crazy. But there's some new issues that we're facing, some just because of where they fall. One issue is their income. They start on the low end of things because of the economy, but things are picking up. So they tend to make more informed purchases because they remember what it was like. So now while they have more disposable income, they ask a lot of questions, even annoying questions, and they also tend to prefer to make purchases with cash and or debit cards, which is why the FSA debit card, HSA card works perfectly. You know, it's their money and they want to use it when they want to use it, not as their employer tells them to use it. That's where these consumer-driven accounts and DPC comes in. The cost is upfront. Another common issue is they're more at risk for mental illness, and it's important that we put money into their self-care. You know, today's millennial employees, they're anxious, they're lonely, they crave deeper levels of human communication and community. It's just an opportunity to incorporate a more holistic approach to health, including mental and emotional well-being. So, you know, options that are flexible, have tech components, options where they can connect with the service and know their fees are up front. It's very, very valuable and very attractive to this generation. And lastly is retention. Millennials are expected to job hop a ton. So this means that you've got to create a health plan that is key. That's a good plan that they like, because that's going to be key in retaining the top talent. So if you are with a client and they have a larger millennial workforce, it's only going to get larger and larger, you've got to keep those employees engaged, happy, and you have to keep those employees there. And so they need to design a plan that fits their wants. You know, consumers are not monolithic. Brokers that thrive in this new consumerism movement going forward, those are the brokers who understand the wants and needs of their customer base. They act on that knowledge, and those are the brokers who are going to be successful. I mean, geez, kids these days. All right, last topic. And man, did I save the best for last. This is great, because we're right at 1 o'clock. Not a whole lot on Hsa and COBRA. I did just want to touch on it quickly. You know, of all the attorneys I've talked to and industry leaders, one thing's certain, none of us know what it actually means. No one understands it because it's constantly changing. It's amazing that I was actually able to break this therapist's Hipaa obligation for Mr. Hsa and get this quote. It's insane. But if you're not up to minute on the date, on the changes behind Hsa or COBRA, again, you need to find a trusted partner, trusted vendors that are, and this is something that we keep up with daily. So we know all the new recent case law about summary plan descriptions. If you can and cannot deny benefits, different appeal processes. And then also this new idea that's come down, employers endorsing the plan. Recent case law shows that if the employer has a hand at all in the plan, it's going to be seen as endorsing the plan, and that plan is going to be subject to Hsa. And it can be something as simple as they said, hey, you should look at this health plan, and hand their employee a pamphlet. A couple of different recent COBRA cases. The COBRA notices, if you have a workforce that typically speaks more than one language, you've got to offer those notices in those languages. Otherwise, you are opening yourself up to big, big liability. And then we do have some common compliance questions, but I do think that we're out of time. So I think what's going to happen is I'm going to put those up on another slide and send those out with the slides so that you guys can see the common compliance questions I get about Hsa and COBRA and the answers that I give. That way, when your clients ask those, you've got those right in front of you. So that is going to wrap up today. Definitely be on the lookout for other webinars for credit soon. And if you all need anything or have any questions, Please feel free to reach out. This presentation was recorded and the slides will be sent out. It will also be put up on our website. Let me see if there were any questions that were submitted right there. I don't see any. Look. Just want to make sure. And again, my email address is there. If you all need anything or do have any questions, please let me know. Doesn't look like we've got anything. So again, if you have any questions about anything we discussed today, our products, compliance services, you want to hear more about direct primary care, please just reach out. It does look like we have a couple questions that came in. Should I answer them now or put them in a... Yeah, why don't I put these questions in a follow-up that have come through? Yeah, what I'm going to do is put any questions that came through in a follow-up message and answer those along with the common compliance questions that I get. And again, lastly, if you guys need anything, our contact information is right here. Please feel free to reach out. We'd love to hear from you guys. Any questions, I'm always happy to answer. I love talking about compliance around this stuff. And I really appreciate you guys tuning in, and stay tuned for our next CE webinar. So thank you very much. Have a good rest of your day.